Think forward. Think Research Channel.
Well, this evening I'd like to present latest innovations in laser vision correction. And basically, refractive surgery is a definition of surgical procedures which have the goal of allowing patients to see well without the use of glasses and contact lenses. And most of the techniques work by altering the shape of the cornea. And there's a whole laundry list of refractive surgical procedures, some of which have been abandoned. The first procedure that gained popularity was radial keratotomy, and that's subsequently been replaced by laser vision correction, specifically photorefractive keratotomy and laser in situ keratom lucis, or PRK, and LASIK. Then there's something called intrastromal corneal ring segments, or INTACs, conductive keratoplasty, or CK. And then there are advanced forms of laser vision correction, and these are wavefront or custom LASIK and PRK. There's some new developments in how we perform LASIK, including something called intra-LASIK. And then there are some other exciting new technologies which have recently gained FDA approval in the United States, intraocular contact lens, and there are a variety of different models which I'll speak of. And then there are some investigational procedures, specifically scleral expansion bands and accommodative intraocular lenses following cataract surgery. So initially, I'd like to speak a little bit about laser vision correction. What is it? Well, there are two forms that are primarily used, and one is photorefractive keratectomy, or PRK, and the other is laser in situ keratom lucis, or LASIK. So first, I'd like to talk a little bit about what PRK is. And what it is it's a procedure in which utilizes an excimer laser system to precisely reshape the anterior corneal surface, and it's able to correct low to moderate levels of nearsightedness, farsightedness, and astigmatism. The excimer laser is a cold or non-thermal laser, and these properties enable us to reshape the cornea without the creation of scarring in virtually all cases. So this is a scanning EM photograph of a human hair which has been etched with an excimer laser. A human hair ranges in thickness from about 80 microns to 125 microns, and the hair has been etched in this area here. And as you can see, you have very precise removal of tissue in these areas with very little or no damage to the collateral tissue surrounding that. Each excimer laser pulse removes approximately 0.25 microns of tissue. So this is a busy slide, but it shows a cornea, which is the curved dome of the eye, having a excimer laser applied to the surface. And what it does is it removes a variable amount of tissue, in this case for low levels of nearsightedness, about 25 to 50 microns in the center, and precisely reshapes it in order for us to see more clearly. And just as scale, you see a human hair measuring 125 microns. Laser in situ keratom lucis, or LASIK, is the most commonly performed correction for the elimination or reduction of glasses and contact lenses. And what this does, it utilizes the same excimer laser system that we use in PRK. The difference is that we create a thin flap through the cornea, and then we elevate that flap. And this is useful to correct low, moderate, as well as high levels of nearsightedness, farsightedness, and astigmatism. And one of the nice things about creating a corneal flap is that there's virtually no chance of producing scar tissue, and that enables us to do higher levels of correction, more significantly nearsighted, farsighted, and astigmatic patient. And one of the most important things, it allows for rapid visual rehabilitation and return to normal activities. The vast majority of patients who have LASIK surgery are able to return to normal activities such as driving, office work, what have you, within the first 24 hours. Well over 98% of patients having had LASIK for nearsightedness, low to moderate levels of nearsightedness, will be able to drive a car the very next morning. And for these reasons, the rapid visual rehabilitation, the ability to correct a wider range of nearsightedness, farsightedness, and astigmatism, it has replaced PRK for the most part to become the procedure of choice for most refractive surgical procedures. So this is an artist's rendition of LASIK, where you make a flap and then you use a laser underneath to remove the tissue and then replace the flap. So the most modern type of LASIK and PRK is something called wavefront guided or custom laser. And this has recently been introduced technology and has been available in the US for the past 2.5 years, and has rapidly gained acceptance because it represents a significant improvement in technology in terms of outcomes and the reduction of untoward side effects. So what wavefront guided technology is, it uses a non-contact laser to measure the refractive status of the eye automatically. And what the refractive status of the eye means is what your glass or contact lens prescription is. So when you go to the eye doctor now, you sit behind a machine and they click lenses back and forth and ask you which is better, lens 1, lens 2, and that's how your prescription is determined. With this device, you look into this device, a laser beam is shown into your eyes, and then it automatically analyzes your standard refraction, which means your levels of nearsightedness or farsightedness and any existing astigmatism, as well as what's called higher order aberrations, which are micro irregularities of the eye. And this advanced technology can then be linked from this measuring device to the laser system and enable us to treat your eye using custom laser vision correction. So what it's designed to do is treat your lower order aberrations, or your nearsightedness, farsightedness, and astigmatism, as well as treating these higher order spherical aberrations or micro irregularities of the eye, which allows for the possibility, potential possibility of supernormal vision, better than normal vision. And as we'll see from the results, it also produces a greater percentage of patients seeing well compared to standard or traditional laser vision correction. So what is wavefront? Well, basically what you have is your eye has these aberrations in the eye. So if you shine a grid pattern in the eye, as seen here, when the pattern exits the eye, having passed through all the structures, it is somewhat distorted. So you have a grid pattern which has some distortion to it. So the ideal would be to get a lens or grind onto the cornea something to neutralize these aberrations, so you'd have a more perfect exiting of this grid pattern and allowing the patient to see through a more perfect optical system. So this is what a commercially available device looks like. You basically put your head here, you look into this little hole, and a laser beam is shown into your eyes. And then the data is transported to this screen here through a computer, and that enables us to analyze the data. Currently, there are 3 systems available for use in the United States, which can be coupled to the excimer laser systems. So again, the artist's rendition of a light that's being an image that's going into the eye, when the image exits, these irregularities cause a waviness of these parallel lines, which would be suboptimal. If you correct those, you end up having a perfectly parallel set of lines coming out of the eye with the corrected aberrations, and in theory have a more perfect optical system. So this is an artist's rendition of somebody with low levels of nearsightedness. So they cannot see the chart clearly, and things are quite blurry. They may be able to squint and see 20/25 or 20/20, but certainly cannot see the 20/15, 20/12.5, or 20/10. So if you correct the standard refractive error, things like nearsightedness and astigmatism, you can now see the 20/20 line is quite sharp. However, if you start looking at these higher 20/12.5 or 20/10 vision, it's not as clear. So the question is, if we correct these higher order aberrations or these micro irregularities of the eye, will we be able to achieve better vision? And this is what the goal or the hope is if we correct these aberrations, we now can see quite clearly down to about 20/10, which would be close to the limits of what the human eye is capable of resolving. So just to go into a little bit about the principles of wavefront technology, there are two traditional methods used to formulate this data. One is Zernike polynomials, and this was the first technology that was used. And then there was advanced software developed, which is called Fourier reconstruction. And basically what happens is, this is the image that comes out of, after the laser is beamed into your eye, you get approximately 240 data points that is analyzed by this system. And it's then put into a complex mathematical algorithm, and based on either Zernike-based data analysis or Fourier-based analysis, it determines a pattern to correct onto the cornea to neutralize these aberrations. So this is how the Zernike, or the first generation of wavefront worked. Basically, this is a profile of a human head, and using the Zernike-based calculations, we try to replicate this complex configuration. Now, as you can see, as you get all the way up to the 10th order, it gets closer to what this shape is, but it's certainly not a very close approximation. And this is also very irregular. You wouldn't expect to see this on a cornea, hopefully. Now, when you go to Fourier analysis or the advanced software, you can see that you get a very, very precise picture comparatively, and reproduces this nearly identically. So the complex shapes are more readily defined by using the Fourier-based software, and it represents a true advance over the first generation of wavefront-guided treatments. So it certainly is an advance that is welcomed. So both of these technologies are effective at generating wavefront-guided laser treatments, but there is some distinct smoothing effect of Zernike's, the Zernike first-generation software. The second-generation software using Fourier-based treatments yields more accurate and it's better able to treat complex shapes. And this advanced version of the wavefront or custom treatment represents a distinct improvement in outcomes of wavefront-guided laser treatments. And we've actually done some studies here at Stanford demonstrating better outcomes using the improved software with the Fourier-based treatments. So that's a little bit of the background. So what can we expect if we were to come in and have treatment for this? Well, when looking at low and moderate levels of nearsightedness and astigmatism, we see the results are quite good, with 99.5% of eyes achieving 20/40 vision or better without glasses following treatment. And that's the legal driving vision in all 50 states, as well as in the European Union. You also have 98% of eyes achieving 20/25 or better, and 94% of eyes achieving 20/16 or better, which is one line better than 20/20. What's impressive is that 90% of these treatments, patients will see as well or better without their glasses following the surgery than they did with their glasses or contact lenses before surgery. And this represents a distinct improvement over traditional laser vision correction, where we did not see these high percentages in terms of outcomes. One of the other issues that we face as refractive surgeons are the patients who've had less than optimal outcomes following initial laser vision correction, whether it be PRK or LASIK. So what we consider these are highly aberrated eyes, and it means that they're somewhat irregular, and up until now there's not been a lot of good treatments for them. So we conducted a study here at Stanford looking at how well custom wavefront guided LASIK would work treating patients who had had previous LASIK or PRK and had less than satisfactory results. So we looked at 120 eyes of 102 patients. Some patients only had one eye they were dissatisfied with, and a couple had both. All of the patients had had previous surgery, either LASIK or PRK, with the vast majority being LASIK, and almost all of them had some degree of dissatisfaction with their vision following their original surgery. And that could range from very mild symptoms, say one eye wasn't as sharp as the other, one eye had a little bit of halo, to people who had very severe problems with ghosting of vision, double vision, multiple image, and so forth. So we looked at standard outcome measurements, things like how well they could see without glasses following the treatment, how well they could see with their glasses if they needed a prescription afterwards, complications, and the main thing we looked at was, were their symptoms resolved with this type of treatment? And then while we were there, we also looked at these micro irregularities of the eye, the higher order aberrations, and these are just specific types: coma, trefoil, and spherical aberration. One of the things we saw, it was very, very good at correcting their refractive errors. We see that 100% achieved 20/30 or better at 3 months, 99% were 20/20 or better, and 72% were 20/15 or better. So these patients ended up seeing quite well with the use of this retreatment using the custom wavefront guided laser. Busy slide, but this shows these micro irregularities. They're called root mean squared by high order aberration, and the light blue bar is preoperatively, the violet bar is 1 day, and I think it doesn't project well. I think it's green and then yellow, but that's one month and 3 months. And as you can see, we have a reduction of the micro irregularities in all of these groups from pre-op, which is the blue bar, to post-op. So we found that in our study, we found we had excellent safety with no patients coming out worse than they did before going into the surgery. We found a reduction of these micro irregularities, these higher order aberrations, and one of the most gratifying things is that most of the patients reported significant improvement in their visual symptoms, and that ranged from completely resolved to 50% better or 80% better. There were some patients in which this did not have the desired effect, and they were left with the same symptoms or slightly different, but this was a very small percent. So one of the nice things about this technology is not only is it effective at treating patients who have never had surgery, but it has the potential to rehabilitate some patients' eyes who have had less than satisfactory results following LASIK. Just as a disclaimer, this would be considered an off-label use of this technology. And what that means is that it has not specifically been studied in a multi-center trial by the U.S. Food and Drug Administration. So there's no formal published studies through that agency. Now I'd like to shift gears a little bit. Another advance that we've seen over the last several years is a refinement of how we perform LASIK surgery. Traditionally, we've done LASIK surgery using a mechanical cutting device called a microkeratome. Recently, in the last 3 years, we've had the introduction of a laser system called Intralase, which uses a femtosecond laser to create the laser flap. And this is a more precise way to create a corneal flap. And that's what the preliminary data suggests. And there were some early trials which indicated that the results using the Intralase or the laser-created flaps might be superior to what was seen with traditional mechanical microkeratome-created flaps. So this is a busy slide, and it's a high-resolution ultrasound, but basically what it shows is here's the flap. This is the front part of your cornea. And I don't know how well it projects, but basically what you have here is the flap is thicker in this region and it's quite thin here and then thicker here again. So there's not very good uniformity throughout the flap using a mechanical keratome. However, when you look at a laser-created flap, you have a extremely uniform flap thickness throughout. So it's just as thick here, here, and here. And that's potentially desirable for a number of reasons. This is another illustration showing regional thickness of the flap. Basically, the red is very thick, and the blues are very thin. So you can see here, this is on this scale, this is greater than 200 microns of thickness, and the blue over here is 120. So we're looking at about 100 micron regional difference in this one created flap. In this flap here, even though it's a little bit more uniform, you still have hot spots where you have thicker areas of flaps and then thinner, which is not desirable because you want to get a nice uniform flap thickness and not cut too thick or too thin. Here are two flaps that have been cut with a Intralase, and as you can see, you have very good boring uniformity. If this was a ski slope, it would be nearly flat in each. So this is a video showing an Intralase procedure. I apologize if it's too much for some people. This stabilizes your eye, and then a contact lens will be put on the eye to create the flap. Now the flap is being created here. This is compressed at 2 times speed, and the laser is shooting back and forth here at 15,000 kilohertz, 15,000 treatments per second, pulses per minute rather, and that is where the flap will be created. The lens is moved, and this is how the flap is elevated. The flap will be elevated. It lifts very nicely, and you have a very nice smooth bed. And then the laser itself, now the excimer laser to do the correction will be applied. The lights will be turned on. You can see the blue fluorescence of the laser treatment, and that's the treatment that reshapes the eye. We'll dry the bed of the eye here, making sure there's no debris, and then reposition the flap with a little balanced salt solution, a little wetting solution, if you will. And that's the whole procedure right there. So you can see it's very, very rapid. So based on the early reports, we decided to bring in the laser about 2 years ago into the clinic, and we began a clinical study seeing whether or not, in fact, the femtosecond laser created flaps were superior to mechanical created flaps. So what we looked at was to enroll somewhere between 50 and 75 patients, and what we did was what's called a contralateral randomized study. So somebody said, okay, I would like to participate, and what we did is we did one of their eyes with a laser flap, we did the other eye with a mechanical flap, and then what we did was treat those patients both with the same laser system under the flap using custom wavefront guided technology. One of the things that we noticed that was been reported in earlier studies were that it was much more accurate. We were trying to create a 110 micron flap. What we got was about 119. But what's really interesting is the standard deviation was much better than what we saw when using mechanical. It was plus or minus 18 microns. When we tried to create a 160 micron flap using the mechanical device, we got about 138. But you can see the standard deviation is nearly 25 microns. So that's significantly worse than what we saw with the laser-created flaps, verifying that laser-created flaps are much more predictable in thickness. This is the visual results without glasses, and this is at 1 week, and we see in both groups 100% we're seeing 20/25 or better, which is excellent. One of the things we noticed, though, is in the intralaser group, which is the light green, in the laser-created flap, we saw that a greater percentage of patients could see 20/16, 20/12.5, or 20/10, these supernormal visual acuity results, than what we saw in the mechanical created group. And this held up at 1 month and 3 months, where you see the same. Again, a greater percentage of eyes at 20/16, 20/12.5, and 20/10 in the femtosecond laser created group. Both groups 100% with 20/20 or better, so excellent in both. But on the higher vision 20/10s, 20/12.5s, we did see superiority in the femtosecond laser created flaps. This slide shows how well people saw without glasses following the surgery and compared it to how well they saw before surgery with glasses. So basically, with the laser created flaps, 43% of patients could see better after the surgery than they did with their glasses before surgery. And we also saw an improvement in the mechanical group, but only 24%, so about half as many saw better in the mechanical created flap group. And this is just a slide just to demonstrate, these are these micro irregularities of the eye, the higher order aberrations. And in the laser flap created group, we see it's a slight reduction in total overall higher order aberrations, whereas in the mechanical group, we saw an increase. And we saw decreases in these specific terms, but greater decreases in the laser-created flap group. Now, of note, we did have one term that increased, and that was spherical aberration, but it increased less in the laser-created flap. So we did worsen spherical aberration in both groups, but much less in the laser-created flap group. So this is a very interesting slide. We administered a questionnaire to patients preoperatively as well as postoperatively, and then we asked the patients postoperatively which eye has better vision overall. And in those patients that had a preference, we found that 2/3 of them at both 1 and 3 months preferred their intralaser or their laser-created flap eye over the mechanical created flap eye. And this was interesting because some of these patients had equal vision in both eyes. They may have been 20/12.5 in each eye, yet they still expressed a preference for the flap that was created with the laser. And this data has also been supported and reported by a study out of the US Navy, as I'll talk about a little bit. So it's still earlier in our study, but what we're finding is that the laser-created flap group showed a statistically significant improvement in their vision without glasses over the mechanical keratome-created group. We also found that astigmatism in the group that had the laser-created flap was lower than in the mechanical created flap group. And there was a strong patient preference for the eye that was treated with the laser-created flap. We've added contrast acuity testing, and this is a much more sensitive measure of vision. Typical vision is taken on a chart where you have a black lettering on a white background. And as you all know, the world is not perfectly black and white. Many times it's shades of gray. So this is more sensitive, and we feel that this may explain why patients who had identical vision on a standard visual acuity chart preferred the vision with their laser flap created eye. One of the things that was seen in the US Navy study was that there was a significant improvement in low contrast vision in aviators that had flaps created with lasers as opposed to those that had flaps created with a mechanical cutting device. So now I'd like to shift gears a little bit and talk about another technology, something called conductive keratoplasty, or CK. And this technology is used for the treatment of farsightedness as well as presbyopia. And for those of you who don't know what presbyopia means going past age 43, 44. And all of a sudden what happens is your arms get too short. So you no longer can see that newspaper or the aspirin bottle, whereas you could before. And what's happening is you're having a loss of elasticity of the crystalline lens, the lens that you're born with in your eye. When you focus that close, it becomes more globular. However, when you get into your early 40s, it becomes less and less elastic, and that's why you are unable to see things at close and either need to wear reading glasses or get into bifocals, trifocals, or progressive lenses. So what CK does is it uses a thin probe to deliver radiofrequency energy to the peripheral cornea, and it causes a controlled heating of the tissue and shrinkage of the tissue, which results in a central steepening of the cornea and a reduction of low levels of farsightedness. The first treatments in the United States were performed here by me at Stanford as part of the US FDA clinical trials. And it did receive approval to treat low levels of farsightedness and also presbyopia by creating monovision. Now, what monovision is, basically, in a nutshell, you have one eye that sees well at distance, and then you take the other eye and you set that so it sees better at near. So you have one eye see well at distance, one eye see well at near, and hopefully you're somebody who can tolerate that and integrate the two images together. So this is just what the machine looks like. It's a small machine, about the size of a DVD player, weighs under 20 pounds. And this is an artist's rendition of how the treatment is done. You have a small probe which applies the radiofrequency energy in the 8 meridians on the cornea. And what that does is that causes a central steepening of the cornea by this belt loop effect, and it reduces the levels of farsightedness or creates a monovision situation for those patients being treated for presbyopia. So the results of the US Food and Drug Administration clinical trial for presbyopia were quite good. It showed that 75% of patients saw 20/20 at distance and read what's called J2 or better, which is stock table size print. And over 90% of the patients could see 20/20 at distance and read newsprint size lettering at near. So this showed an excellent safety profile. There were no patients losing lines of corrected vision, and it's approved to treat low and moderate levels of farsightedness, and is the first surgical procedure that has been specifically approved by the US Food and Drug Administration for the treatment of presbyopia by creating monovision. Now, it sounds great, but there are a couple of caveats. One is that not everyone tolerates monovision. It's a compromised situation, and what you're doing is you're taking one eye and you're making that eye see well at near. The flip side of that is that eye no longer sees well at distance, and some people will tolerate this and their brains will acclimate to it, but there are others who cannot get used to this. So it's imperative that if you are considering something like this, that you do a contact lens trial and see whether or not you can get acclimated to it, because the last thing you want to do is a permanent or relatively permanent procedure and it turns out you don't like it. So next I'd like to shift gears into intraocular contact lenses known as ICL or phakic intraocular lenses. And this is a technology which uses a thin plastic lens and polymer materials which are placed inside the eye, and they're used to correct high and extreme levels of nearsightedness and farsightedness. So these do not do anything to the corneal surface, so there's no chance of scarring on the cornea. And this provides full correction of extreme levels of nearsightedness and farsightedness, which cannot be treated with traditional laser vision correction. So these are patients who have really no other options outside of wearing either contact lenses or glasses. And even though they comprise a very small percent of the population, they disproportionately will seek out solutions for laser vision correction and other technologies because they're the ones that are most handicapped by having such high levels of correction. And the reason is that if you wear if you're extremely nearsighted, say -10 to -20, you have to have glasses that are quite thick, and they can cause problems in terms of how much they weigh. It really is very ineffective with peripheral vision. Contact lenses, they work well in some patients, although some patients are unable to wear them. So these patients really have been, many times, are desperate to have some solution, and this fortunately now offers them a solution. The FDA studies were conducted in part here at Stanford, and one of the lenses received FDA approval in September of 2004. This is the model of lens that was approved, and what you have here, this is in the eye, and this was a nearsighted patient who had this lens placed for extreme levels of nearsightedness and could see quite well following the surgery. It's not visible to the naked eye. This is magnified many times. So in our studies, we looked at extreme levels of nearsightedness, and the numbers ranged from -8 to -20, which would be considered, as you know, in the schoolyard, Coke bottle glasses. And for farsighted levels, we looked at +4 to +12, which would also be very strong magnifiers. And we were one of 15 investigational sites in the United States participating in the U.S. Food and Drug Administration trial. So the results of the trial were that 93% of patients could see 20/40 or better, 78% 20/25 or better, and 44% 20/20 or better. Now, if you look at these numbers and then you look at what custom LASIK can do, you say, well, wait a minute, these numbers don't even come close to what I can get with custom LASIK. But you have to remember, the custom LASIK is looking at patients who on average were about -4. These patients were on average -13, so it's more than 3 times as nearsighted, and no laser vision correction is effective for people in this range of vision. So this is really quite impressive results. The last couple things I'd like to talk about will be investigational refractive surgical procedures, one of which is scleral expansion bands, and the other would be accommodative intraocular lenses following cataract surgery. So scleral expansion bands were the first surgical procedure developed expressly for the treatment of presbyopia. And what they did is they used 4 plastic segments, very small transparent bands, which were placed around the white portion of the eye in the 4 quadrants of this, what's called the sclera. And what the idea was, it was to expand the diameter of the eye. And the theory, which was controversial, was that this expansion of the white part of the eye might enable the lens inside your eye to become more elastic and have the muscles work better. And that would therefore reverse the loss of the ability to see up close or accommodate. And we were part of a multi-center clinical trial here at Stanford Phase 1. This is what the segment looks like, artist rendition right here. They're transparent, and they're put in the white part of the eye. The overlying clear tissue is lifted up. You make these little segments here and here, so you can see these little grooves, and then you insert these bands in the eye, and that's what it looks like after it's put in, and that would be in all 4 quadrants. And then this tissue would be what's called conjunctiva, would be closed on top of it. So there were 6 investigational sites, including Stanford. We enrolled 30 patients, 1 eye each, so 30 eyes. The patients had to be 43 years of age or older, and they really had to only have a problem with seeing up at close. They couldn't need glasses for distance or have high levels of astigmatism. So we're really truly looking to see whether this would restore the ability to see at near. So the promise was quite good. If this technology worked, it would be the only surgical procedure available for the correction of presbyopia. And if it's successful, it would be of enormous benefit to virtually all patients over the age of 43 to restore their near and reading ability. However, the Phase 1 Food and Drug Administration clinical trials were inconclusive with many patients showing little or no improvement. The ones we did here at Stanford had no improvement at all. And the procedure has been abandoned because it does not work, at least in my opinion. So lastly, I'd like to touch upon accommodative intraocular lenses following cataract surgery. So what cataract surgery is when the lens in your eye becomes cloudy, then you have what's called a cataract. So a cataract is a cloudy lens, the lens you've been born with. So traditional cataract surgery functions by removing your cloudy lens and then placing a plastic, acrylic, silicone, what have you, lens in the eye. Now these are what's called fixed focal length. So they're set for one level of distance. You can have distance meaning 6 feet in infinity. You can have intermediate, where reading, say, 24 to 36 inches, or you can have near. But you cannot have all 3 levels of vision with the standard lens. So an accommodative intraocular lens has the potential or the promise of restoring clear vision at distance, infinity, driving your car, intermediate, your dashboard, food on your plate, and near, reading your stock tables, reading your Palm Pilot, reading your cell phone. And the first lens has been approved by the U.S. Food and Drug Administration, and it's called the crystal lens. And there are several other manufacturers with other novel lens designs which are currently in FDA clinical trials. So the preliminary data looks good. There is some question as to the long-term, how well these work, and they're just slowly starting to catch on in the U.S. So at this point in time, I think it's more of a wait and see before I'm ready to say that these things work quite well. However, it is promising, and even if this particular lens turns out not to work as well as billed, these other lenses that are going through the clinical trials use a variety of different lens designs, and hopefully over time we will come up with a reliable way of restoring accommodation. So there's a bunch of future developments in refractive surgery that we're looking forward to. I've shown you that there have been some improvements already for our customer wavefront guided technologies, but we still have a long way to go. We need to have lasers and imaging devices that are able to treat irregular corneal surfaces, not only following LASIK and PRK, but in cases of trauma or patients that have had complex surgeries such as corneal transplantation, who really would benefit from this technology. Advances in laser vision correction that have lasers that are capable of improving vision over what can be obtained with glasses or contact lenses. As we see, what our current data does for us is we have excellent results, but we're still not at 100% 20/16 or better, 20/12.5 or better, and we may never get to that level, but we're constantly striving to get the vast majority of patients to that level. The human eye is a complex structure, and when you work on living tissue, you can never eliminate completely wound healing effects and Mother Nature. So, but as we get more and more advanced, hopefully we learn how to modulate tissue healing, and we'll get better devices. One other advance that's exciting is that there's a lens design which can be used for cataract surgery, which could also be used for these implantable contact lenses, where after the lens is put in your eye, the lens can be adjusted. So what happens if you have a cataract surgery or a implantable lens for nearsightedness or farsightedness, usually you get very close. Say 95% of the time you're just dead on accurate. But if you're looking at 2 to 5% of patients who are slightly off, that means that they then need a glass prescription for low levels of nearsightedness, farsightedness, or astigmatism. And many patients are very disappointed with this because they were hoping to become glass-free. So this technology allows you to put the lens in the eye, allow the patient to come back. We measure the eye. If it's not exact, we can then adjust it to make it more exact after it's in the eye. And that avoids doing things like going back surgically and having to remove a lens and put a new one in, or add an additional lens, which all carry extra risk with them having a second surgical intervention. And I'd like to thank you for your attention, and we can open it up for some questions and answers at this point in time. The question is, does the presence of glaucoma have any effect on this type of surgery? And I guess it depends on which of the technologies we're talking about. If you have glaucoma and you're interested in laser vision correction, it depends on a number of issues. How advanced is your glaucoma? And that would be on a case-by-case basis whether or not you can do it and what type of surgery you can do. If you have advanced glaucoma, then certainly you wouldn't want to do any kind of an elective surgery. However, you could do, and people who have glaucoma can have cataract surgery successfully. So when referring to accommodating lenses, that would be something that you would be able to do. The question is, how comfortable am I with the long-term results with LASIK and PRK, I assume, or laser vision correction, because the technology has not been out 40 years. And it's a valid question. There are some studies that have recently been published. There was a 12-year study looking at laser vision correction using PRK, and actually it's been updated to 15 years. PRK was introduced in about the late 80s, so we're not quite at 20 years yet, but we're getting close to that. And LASIK was introduced in 1991. There are a paucity of good studies on it. However, if you look at those studies, in the 5-year and the 10-year studies, you basically are finding that, at least when you're looking at low and moderate level corrections, that it's quite stable, and we're not discovering a whole series of untoward side effects that we hadn't anticipated. Now, the only way to know a 40-year data is to, come back in 25 years and ask me, if I'm still around. But and that's an interesting question. I'm asked that all the time. It's interesting. If you look at most of the medicines you're probably taking now, very few of them have been around for longer than 10 years. So, as well as things we ingest, like NutraSweet and what have you. So, it's a valid point, but no, I can't answer it. But by all indications, at least out to where we are, it looks to be safe and stable. So the question was, in the study comparing a mechanically created flap to a laser-created flap, the patients expressed for those patients that had a preference, 2/3 of them reported that the eye that had the flap created with the laser was better vision overall. We did not provide any parameters to the patients. We basically said, the question was, which eye do you feel has better vision? And that could be any number of things, obviously. We also broke it down and asked things like, very detailed questionnaire, do you have glare and halo? Do you have daylight sensitivity, preoperatively and postoperatively? We asked all those questions preoperatively and postoperatively. But many of the patients had identical vision in each eye, at least measured by standard Snellen vision with the black lettering on the white background. And we were a little bit surprised. If both eyes are seeing just as well, why? And that's why we added this more sensitive test, which is contrast sensitivity, because it may turn out that they preferred it because under dusk conditions or low light conditions they saw better. Once we have a more thorough analysis of this study and the questionnaires, maybe we'll be able to answer that more specifically. Maybe because they had the same vision but had less of these micro irregularities of the eye. Maybe they had less astigmatism. We just don't know at this point. The question is, what is the percentage of patients, as I heard it, and I'm going to try to say what you said. The question was, what is the percentage of patients who have double vision, glare and halos, and ghosting of vision following laser vision correction? And that's not so easy to answer because there are a wide variety of patients. There's low levels of nearsightedness, moderate levels of nearsightedness, high levels of nearsightedness. There's farsightedness with astigmatism. So looking at the most common, say, somebody who has low to moderate levels of nearsightedness with some associated astigmatism, if you look at those group, because that's about 80% of who has laser vision correction, using the modern laser systems, wavefront guided laser systems, we see about a 2% incidence of glare and halos. A very useful site to go to evaluate this data would be to go to the U.S. Food and Drug Administration site. It's www.fda.gov. And in there, you can actually go in and look at each of the laser manufacturers and download what's called a patient information booklet. And in there, there's detailed statistics about how many patients had halo before surgery, how many had it better after and worse after. And those questions are more easily answered by looking at that data because it's real good science and the statistics are all provided there. The question is there a difference between farsightedness and presbyopia? And I would say the answer is yes, but that's probably the most commonly misunderstood definition. What farsightedness means is that you'd think you'd see better at far, but what happens is it means you have to wear plus lenses to see far and also stronger plus to see near. So presbyopia, everyone past age 43, 44, 45 becomes presbyopic. So if you're farsighted, you'll have the glass for the distance and then you'll have a glass for near. If you're nearsighted, you have to have a little thing added on the bottom. So there's a difference between farsightedness and presbyopia. The question is, there's some newer technology that's used with the laser system. It's called iris recognition software. And what this is, it's an advanced type of laser which uses what's known as biometric scans. So you hear a lot about this now with security. To get into a building, you either have to put your fingerprint in, or they can actually do retinal scans or iris scans to identify that you're actually the person you're saying you are. So what iris recognition is the laser, the laser that measures the image on the information from your eye, takes a detailed picture of the iris, the colored portion of your eye, transports that data to the laser, and then when you're under the laser, it more precisely aligns your eye under the laser. So it ensures that the pulses of laser will be delivered more accurately and treat the eye more correctly. So in theory, that will even improve this type of treatment, wavefront guided treatment, over what we currently have and could represent a significant advance. So the question is, am I aware of anything that would allow older folks see well at all levels of vision? Well, nothing at this point in time has proven successful. One thing that is possible is these accommodating lenses. And some people advocate removing lenses before they become cataractous. It's called clear lens extraction. So they will remove your lens as if you had a cataract, put in this accommodating lens, and now you can see, in theory, distance, intermediate, near, like you're 30 years old again. That's a little bit sort of on the fringe, and I'm not sure that I would advocate doing it at this level because I'm not convinced yet that this technology is really proven, and I wouldn't rush out personally for it. The question is, she was reading an article about an accommodating lens, and what it was is concentric circles. And there were a couple, that was a recently approved model. It's, I believe it's called a Restore lens. And basically what it is it's a multifocal lens. So you have concentric rings. Some are set for distance, some are set for intermediate, and some are set for near. And that works well for some patients. One of the problems with those lenses is that it does cause a reduction in contrast vision. So if you're a truck driver at night, that could be a problem for you. There is some degree of patient intolerance. So some people can't tolerate it. They'll get halos around objects. And so again, I would not rush out to have that if I was a 45-year-old just wanting to get out of glasses. There have been people who've had cataract surgery and had similar types of lenses put in and have been miserable and had to have them reoperated on and remove them. So that's a relatively new type of lens, and it has great initial press, and it looks like it works well. But again, that's only been out now maybe 3 months. So it really needs to stand the test of time and have larger numbers of these implanted before we really can declare success. So the question is, if you have this surgery, if you've had any of these surgeries, what happens as you age and if your vision changes? And that's a good question. Sometimes we'll do surgery in young people, 20 years old, and let's say you do LASIK, and then they're -4, and then when they're 50, they were going to be -5. So you'd have the difference, -1. So in many of the procedures, you can go back and do, as I said, what's called enhancement or touch-up or retreatment or reoperation, what it really is. If you do something like monovision, it's not as titratable. I mean, monovision works well, especially in your early 40s towards 50. At some point, it stops working as well, because if you end up having 3 levels of vision, there's near, intermediate, and distance, and you can only choose 2 of the 3. So most people end up seeing okay at intermediate and then distance, but lose the near, because otherwise, if you have good near and good distance, you lose intermediate, your computer terminal. If you're at a gallery looking at an piece of artwork, you have to stand very far away or get too close, and often the barrier doesn't let you get that close. And people can have trouble getting onto a bus or walking upstairs because that area is out of focus if you have one near and one distance and not the intermediate. So monovision is a compromised solution, and it's not a long-term solution for reading. Even when it becomes less useful for reading, it still is useful for the dashboard of your car, food on your plate, and that sort of thing. So it does have a limited life from a reading standpoint, but does have utility above and beyond that. The question is, if you have monovision, she thought that it would stay there long term. Now, if we're talking about doing something on the cornea, like a laser vision correction or CK, it does not, the effect stays forever, or it can stay long term. Some of them are more temporary than others, such as CK. But it depends where you have it. Just like if you say you're 44 and you just start having reading problems, you only need a slight amount of power to see close. You still can see your computer monitor, your dashboard of your car. It's just as you get older, when you get into your 50s, all of a sudden, even those things become blurry. So if you have a procedure on your cornea, it will not last long-term for reading, because initially, when you're 30 or 20, you could see distance, intermediate, near. You don't need any glasses. When you hit 45, 46, the thing you start losing is the ability to see small objects, the aspirin bottle, stock tables, what have you. When you hit 50s, all of a sudden now your dashboard's blurry as well. So if you have monovision at age 45, you probably get reasonable near and intermediate till maybe close to 50. But after 50, your near is not as good, and you have to start using reading glasses. Now, if you're talking about accommodating lenses, the lenses that go in the eye, assuming they work, then that would be a permanent long-term solution. So that does not change with aging, because that works at the root of the problem. That goes and replaces the lens which has lost its elasticity. Well, thank you for your time.